evening, everyone. Thanks for joining in and thanks for sending in your cases. I think we are past 7. So without further ado, I'll hand over the platform to Basis from Hinduja to present his case. The chat is open, so please feel free to put in your comments and suggestions. Over to you, Basis.
Yes, sir. So in this case, 7.5 years old girl, born out of non-consanguineous union. On 9th of last month, around 1 month ago, she had this history of fever, vomiting, multiple episodes, and headaches. Headache was mild, and just lasted for around 2-3 days. So she got admitted for that. And around 17th of June, that's around 1 week after this headache, whether it's fever, headache, and vomiting, she had this sudden onset facial deviation with an inability to close her right eye. And during that hospital admission, only within 3-4 days, she developed increased drowsiness. During that also, she had this one episode of seizures, and followed by this seizure, she had this encephalopathy. And for this encephalopathy, she was not able to maintain her airway. She was intubated, put on mechanical ventilation. So since then, she has been on mechanical ventilation. So at around exactly about two weeks after the onset of fever, headache, and vomiting, there is gradual worsening in the form of she had this one episode of long seizure, then followed by she became encephalopathic, and she was intubated because of poor airway maintenance. So on examination that time, she had GCS of this, and she had some slurring of speech. This is before intubation. She had some gaze palsy, and she had upper motor neuron signs also, some cerebellar signs also. She had signs of meningeal irritation that time. So roughly 2 weeks into the illness, she had progression of these symptoms, developing into encephalopathy, following which she was intubated.
We have 2 sets of scans, so we'll come to the first scan. So this is, I think, done on 23rd of June, right?
Yeah, this is around 2 weeks into the illness when she developed this encephalopathy when she was intubated.
Okay, fine. So diffusion ADC sequences, possibly you can appreciate some punctate areas in the middle cerebellar peduncles out there, and possibly in the cerebellum. But other than that, maybe some punctate foci on the right globus pallidus and postlimbital capsule. No significant changes on diffusion other than these punctate areas. I think the T2s and flares should better demonstrate the extent of the abnormalities. Yeah, coming to the T2s, you can appreciate there is some degree of cortical volume loss. And there are these multifocal abnormalities, especially out here in the right basal ganglia, the internal capsule on both sides, involving the brainstem, that is more on the right side, also involving the dorsal aspect of the brainstem. And coming down to the cerebellar white matter and inferior cerebral hemispheres, you have these patchy areas of T2 hyperintensities. And on the SAT sequence, you can appreciate the extent of the lesions on the brainstem and also in the upper cervical cord. I don't think we had a cervical cord exam screening, but yeah, these are the extent of changes. Suprainfratentorially, involving the gray and white matter structures, multifocal, asymmetrical in distribution, with a background of some degree of cerebral volume loss. On the SWA sequences, there was no areas of blooming, suggestive hemorrhage or calcification within the abnormal areas. Post contrast, the right basal ganglia and thalamic or internal capsule abnormalities has these punctate areas of enhancement. The cerebral peduncles, again, on the right side has these changes, and more predominant enhancement pattern was in nodular enhancing pattern was seen in the posterior fossa along the dentate nuclei, peridentate region, and the middle cerebral peduncles. You can appreciate it is more on the left side. Coming more inferiorly, again, posterior fossa has more predominant changes, punctate areas of enhancement. Brainstem also you can appreciate on the SAT sequences, and also in the supratentorally on the SAT sequence you can appreciate possibly along the perivenular distribution you have these areas of enhancement, punctate areas of enhancement demonstrated. So predominant changes of enhancement are in the posterior fossa. Some areas of enhancement also demonstrated in the supratentoral brain in the basal ganglia and the internal capsule. Child had facial nerve palsy, so you can appreciate again there's abnormal enhancement of the facial nerves more on the right side in comparison to the left. So these were the changes on the first scan.
So on initial evaluation, her CSF showed 160 cells. They were 100% lymphocytes. Sugar was 49. Protein was normal, and gene expert pyrosequencing was negative. But her PCR showed didn't give any viruses, but anything was not mentioned about the viruses, but had given the Salmonella typhi. This was found in the CSF PCR. And the CSF was repeated after 1 week. That showed cells were 194, again lymphocytic. That time 90% lymphocytes. Protein was slightly higher that time, 77. Sugar was normal. Gene expert for MTB, I think it was repeated, was again negative. And her counts were high, always 50, 15,000. So that time the MOG was repeated second time, that was negative, and she was being evaluated for this SLE or they. It's not there the ANA profile, but ESR was 40, CRP 28, and ferritin was also 257. So this is 1 week into the illness when she was still intubated. CSF was still showing the same picture, lymphocytic picture with slightly elevated protein this time. Whereas other investigations came out to be negative.
Okay. Then we have a follow-up scan a week later. And on the week later, you can appreciate some new changes in terms of diffusion abnormalities. Again, in the center semioid on both sides. Here you can appreciate more on the right side, but again, bilateral punctate areas of distributed diffusion. On the contralateral basal ganglia and the capsular white matter, again, you have these areas of abnormality on the diffusion various sequences, which was not seen on the initial scan. The rest of the posterior fossa and the deep brain nuclear changes and bracing changes looks somewhat similar, at least on the diffusion various sequences to the first study. So new changes in terms of diffusion on the cerebrum semioval and on the left basal ganglia capsular white matter. On the T2A sequences, again, this abnormality on the left basal ganglia thalamus has progressed as a new change in comparison to the first scan. These punctate abnormalities in the cerebrum semioval, again, which is not clearly seen on the first scan. Posterior fossa findings, I think, was seen on the initial scan itself. But yeah, these are the new changes on the second scan. Again, no areas of hemorrhage on the established sequences. I think angiography was done. No stenosis per se in the supratentorial intracranial arteries. There's some tortuosity of the vertebral arteries, especially on the right side. But other than that, I am not able to appreciate any other significant findings. Final screening was done. We don't have an axial sequence, but I'm not able to appreciate any focal lesions. Maybe there is some cervical cord swelling out here, but I don't have the corroborative axial sequences. On the post contrast, in comparison to the first study, the posterior fossa enhancing lesions have reduced, but there are again these punctate foci in the cerebrum semioval, which are not seen on the first scan. So punctate areas of enhancement, if you appreciate on the SAT sequences, more along the perivenular distribution. And the posterior fossa enhancement has decreased on the follow-up scan. I think the clinical team has raised the questions of
She had a history of travel. Can I just Basit? You can say Basit about the travel history.
So after the initial presentation, she was started on ceftriaxone. She was given acyclovir for some time, and with clinical worsening, she was given steroids. Also, they had started AKT for 2-3 days. Of this lymphocytic predominance, protein had also increased, but MOG, everything was not sent that time. The history, there was something else in the history that she had traveled to Tamil Nadu, and she had just come back from this. So for a month, she was in Tamil Nadu. There was a query history of some fever for 2-3 days. So there was a history of travel also. They had even started her on azithromycin. She was given doxycycline, suspecting that she might have some sort of this typhus. So that was also significant in her previous history, like she had history of travel. So after that, she was giving steroids. AKT was given for 2-3 days, but we stopped after that. And with this clinical impression of it could be a primary viral thing. In second scan, it was showing that in the SAG, if you can check on, they were showing the perivascular, those typical contrast enhancements. So our query was whether this is a primary viral disease or it could be some other autoimmune like GFAP, is a possibility of a GFAP astrocytopathy. So there were the mere concerns, or she had history of some swimming also in some. So the one possibility was whether it could be some amoebic, otherwise it was not fitting in that amoebic thing. So our main concerns were whether it's a primary viral versus this GFAP astrocytopathy, and query remotely and amoebic. HLH was also thought to be a possibility that time. So now today only we have got an update that her CSF GFAP is negative.
Okay.
What is your take on this? Is the MRI, could it be like GFAP? So the atypical infection, she had a travel to a forest. She had swam in some water pool or something, which was not very clean. And with this ongoing CSF lymphocytic predominance in the CSF, whether atypical infection versus any immune mediated or inflammatory.
Yeah, Rafnila, I was thinking maybe it's a post-viral demyelination is what I was thinking.
Listeria, someone has asked, Listeria is also
Yeah.
done in the CSF, which is negative.
Yeah, so
And
imaging
she has received ampicillin also. She has received ampicillin suspecting Listeria.
Yeah, the predominant features of trauma encephalitis with the degrade nuclear changes. So one of the thoughts was a post-infectious autoimmune inflammatory demyelination. As you have said, MOG has come out negative, but still a seronegative positive condition can be positive. GFAP, as Basit has already mentioned, these perivenular enhancing pattern. But is the presentation slightly shorter in duration? I mean, longer in duration for GFAP, like a subacute degeneration? Our child may be more acute with the rule that out. And now GFAP at least has come out negative, is what I understand. And the other parts, HLH was also raised. I think microbleeds would have been more helpful, but the posterior fossa findings appear somewhat like what we see on an HLH. But again, labs do not, I think there's no cytopenia or abnormalities on the blood picture.
Yeah, so but isolated CNS,
HLH. Yeah. If you see the imaging pattern, it looks similar, but does that improve on 1 week steroid course? At least the posterior fossa findings is, I think that is a, do the HLHs improve on medication on steroids was one query I had. Then sarcoids and given the cranial nerve involvement and these, again, you have these punctate areas of enhancement, all enhancement, but the pituitary gland and stalk was normal in our case. Lymphoma is unlikely. I just wanted to highlight the imaging findings. This all looks somewhat similar to a GFAP or Klippers-like syndrome, but these are all different presentations. Some are vasculitis related changes, some are MOG related changes, as you can see out here, and some are GFAP related abnormalities. If we concentrate on the posterior fossa findings. So imaging differentials, as you have already put out, is, I think I'm considering the same. But yeah.
One more thought was Klippers, and I think someone has messaged also. What do you think about that? He has a lymphocytic CSF also.
Yeah, so these are all Klippers. I mean, the punctate areas of Klippers, and that's why I asked what was the intervening medication given, and the child has responded to steroids.
Steroids and IVIG both were given actually in that 1 week.
So the posterior fossa findings have improved, meaning at least the enhancement pattern has improved in comparison to the first scan. So a steroid response, but again, Klippers is more, C stands for chronic in nature. So does this come under chronic? What was one more question?
She is now 3 weeks into the this last CSF was almost after 3 weeks of the illness.
So at least a steroid response part is there for Klippers, and the enhancement pattern, which is also improving, goes with Klippers.
One more thing, she also has, there was also a question about vasculitis, small vessel, and she also had some proteinuria. And in urine, there were some episodes of proteinuria and all, which are reduced, but the rheumatology input was also taken, and they were thinking of some vasculitis or Behçet's. What is your take on that?
Again, some hemorrhagic changes would have been more helpful, specific for vasculitis. More subcortical cortical involvement, angiography also demonstrating any abnormalities out there, which is actually not seen in our case. And if you see small vessel, I mean, the area of involvement in the white matter is, I can accept a small vessel, but the deep brain nuclear structures, posterior fossa, cerebellum, and these put most probably in the medial vessel kind of territory.
Okay.
Yeah, and vasculitis, if we are thinking, then again, the diffusion changes are not seen on the first scan. There is basic ganglia abnormalities, and correspondingly, there is no diffusion changes. So at least my acute to early subacute vasculitis would be less likely on this.
Okay.
Okay, let's see if people have mentioned. Okay. Klippers, yes. LCH, yeah, I think that was considered, but I don't think matches that.
ACE level for psychoid, do you think? No mediastinal lymphadenopathy is there.
Yeah. I mean, if you in the imaging pattern, it looks there is a possibility of the sarcoid-related changes on the posterior fossa, but it was more of an infiltrative region than in the pituitary gland. The stalk at least should have been involved. Cranial nerve involvement is there. That is again one of the features for sarcoid. But meningeal enhancement per se is not seen in our case. So I would put it maybe lesser
Lower.
likely on the lower on the differential. Yeah. Autoimmune encephalitis, I'm not sure if that shows any typically any enhancement. Again, is not very typical for autoimmune. If you're thinking of the NMDRs and all those types, and there's more cortical.
There's not much
Yeah.
seizures. Clinically, she doesn't have only one episode is there. No much
Yeah.
seizures, no movement disorder per se.
Yeah, from Torrent mind. They're using GABA 20 and Tor lever bands.
Okay. So, what about this amoebic thing?
Again, amoebic will be more focal lesion. Again, we'll have more hemorrhage is again more common feature for amoebic encephalitis.
Okay, so you still feel for most likely first thing is post-infective.
Post-infective and flippers also is a flippers also is a possibility given that the response to the steroids and the IVGs on the follow-up scan and lymphocytic predominance changes.
Okay.
So if you see, so this is the first scan. You look at the posterior fossa findings, and on the follow-up scan, there is very minimal residual enhancement. So there is some steroid.
Deep gray has increased. The deep gray matter involvement. Opposite side.
Yeah. And child is still intubated?
Yeah. Slightly better, but still on.
Yeah, as I mentioned, slippers also is slippers is a variant of flippers. So it stands for supratentorial involvement. So that can also be there. Yeah.
How do you confirm that?
I'm not sure. Imaging wise, again stands for responsive to steroids, but maybe biopsy is the one. But I don't think we biopsy the child. I mean, at least.
No, I don't think so.
So S stands for supratentorial involvement of the same posterior fossa abnormality. So slippers is a variant of flippers.
Okay.
Oh, so you should do a HLH, more detailed HLH assessment.
So maybe a genetics or a perforin assay, or what do you think?
We can whichever you want to do. That can look like clippers. Many clippers turn out to be that only.
Okay.
Okay.
Thank you.
Thanks. Let's see if Sridhar. Okay, Sridhar just messaged will present it at the last. Okay, we'll get to the next cases. Okay, Anas, if you're there.
From Amlapuram was apparently asymptomatic till 6 months of age. From 7 months onward, parents have noticed regression, initially in social milestones like loss of social smile, then not fixing, not tracking to sound or light. Then there was motor regression as well, unable to roll over, unable to sit, and simultaneously increased tightness of all 4 limbs. There were no seizures, spasms, or startles, anything from history. The born to non-consanguineous elder child also died at 6 months, but she didn't have any regression. It was sudden death. She had vomited and aspirated. Within 2 hours, she died. There's no clear reason that how she had died. So this current girl's examination, she's well thriving, slightly on the lower centiles, but within centiles, no organomegaly, no dysmorphic features, hair, skin were normal. The vision was inconsistent and auditory responses were also inconsistent. No cherry-red spot. As from history, again, confirmed spasticity in all 4 limbs with brisk DTR, suggesting pyramidal signs as well. So clinical impression was motor and cognitive regression. Probably lysosomal steroid disorder was one possibility from history, and mitochondria being another, or Canavan, Scrabis, AGS. These were clinical differentials before the MRI.
Okay, so as Anas mentioned, yeah, possible clinical differential with some negative points out there. With that, we'll go on to the imaging. So diffusion ADC sequences, you have this diffuse change of vesicular diffusion, almost cavitatory type leukodystrophy presenting in the supratentorial white matter. The peripheral areas of the cavity demonstrate vesicular diffusion. There is relative sparing of the deep brain nuclear structures, some punctate foci in the posterior limbical capsules on both sides. The mesial temporal lobes have these focal abnormalities on diffusion various sequences. Yeah, so predominant changes are in the white matter, cavitatory changes involving the supratentorial white matter, relative sparing of the basal ganglia, thalami, and also the posterior fossa structures. On the flare sequences, you can appreciate the cavitatory lesions, the central rarefaction or cystic changes in the bilateral deep cerebral white matter. Again, these punctate foci on the posterior limbical capsules and relative sparing of the deep brain nuclear structures, brainstem, and the cerebellum. On the SAT sequence, you can appreciate there's involvement of the corpus callosum. The middle aspect of the corpus callosum is more predominantly involved. If you look at the cervical cord on the SAT sequences, you have more, I think we don't have an axial cut, but it looks like more dorsal predominance involvement of the cervical cord. Spectroscopy was done, and on spectroscopy, there is a significantly inverted lactate peak, and there's also a lipid peak out there. Rest of the peaks demonstrate reduced reduction in terms of the size. Based on that, based on the imaging findings, we thought the primary differential or possibility was a mitochondrial leukodystrophy, given these cavitatory changes as described in this this paper from CHOP, and you can appreciate even the corpus callosum is a clue with the middle brain involvement. So they can present with varying involvement of the white matter changes. There can also be involvement of the deep brain nuclear structures, the posterior fossa structures in some of the complexes. Our case, I think we are thinking of possibly of complex 1 nuclear genes or multiple mitochondrial dysfunctions. Can also present with these confluent necrotizing leukodystrophies with sparing of the deep brain nuclear structures. With that, I think genetics was carried out.
ETP11A, heterozygous mutation, autosomal dominant, but it's a VUS variant. No pathogenic variants are detected in the genetics. This was both whole exome and mitochondrial.
Okay. So yeah, we just wanted to check with the group and the audience if I don't think we are,
because already mitochondrial genome has also been tested and we have given the details. So that's what we're wondering, how is there any other way to prove, get some other further evidence? The gene what they mentioned, it's not a match. At least the phenotypes mentioned is not a match.
yeah, imaging also it's not a match. So we needed consensus on the group.
Recent some markers for mitochondrial disease in the serum. I don't know, FTGF. I can't remember now. It's being done in India now. Can I just get back to you in 2 minutes?
Sure, sir.
So at least in the chat, yeah, most of them are, yeah, Dr. Namrata, no calcifications, vanishing white matter, differential, yes, but I mean, yeah, mitochondrial, yeah, most of you are saying mitochondrial vanishing white matter. So we all agree that the gene does not match in terms of imaging phenotype, and mitochondrial is high on the list, followed by vanishing white matter. CSF proteins, Anas?
We have not done any CSF because imaging was quite, we thought it's a clincher. So we didn't do any MRI, CSF.
Okay, can I just tell you, there's this FGF21 and GDF15. And these are in diagnostic biomarkers. I think FGF21 is more reliable. It's seen in mitochondrial encephalopathy specifically. And this is being done at there's Dr. Anil Jalan, who has just started this testing. It costs about 7,000 rupees or something. So if you guys are interested, I can send you the number of Dr. Chala, and then you can ask.
Sure,
Yeah,
thank
you can say that. Yeah, thanks.
you. Thank you.
Do we need to do a?
21.
Okay, so no
It-
muscle
I
biopsy.
Well, that yes, but these are
Okay.
biomarkers for childhood mitochondrial encephalopathies.
Got it.
And before you do the muscle biopsy, if you have this thing, this is approximately it's about 70-80% sensitive and specific. In fact, I'll just tell you how much exactly it is. 0.87. So
Yeah.
anyway, so I think that's a good idea to just get it done and see. I was also thinking, I've not really heard of it, but when I got this message from him, I looked it up, and that's the time when I think maybe you can do it. I'll send you the thing on the
Sure,
chat.
sure. Yeah. Okay, Anas, got it.
Thank you.
All right. So we await a follow-up. Okay, if Dr. Tajul says cavitating dysmyelination looks predominant on the posterior quadrant. Okay. All right. Isa concludes that yeah, to suspect for mitochondrial disorders. Got it. All right, we'll get back to you if you have a confirmatory diagnosis in the subsequent sessions. Thanks. Razi, over to you.
This is a 1 year, 9 months old boy with normal motor development, had normal speech cognition as well, but speech regression from last 3 to 4 months. And there was loss of appetite and weight loss almost since past 4 months, and very irritable screaming, and lost social smile, poor response to name call, and poor socialization was there. Born to non-consanguineous parents, no perinatal issues. On examination, weight was 7.5, which was failure to thrive, and head circumference was 45 centimeters, and poor eye contact with generalized hypotonia, and DTRs were elicitable. Gait was normal. So initial failure to thrive with autistic regression with severe loss of weight in past 4 months. So MRI was considered. This side.
Okay.
क्या वो नहीं गाड़ी चला रहा हूँ बार बार
All right. So on the diffusion variant sequences, you can straight away go on to the third image, and you can appreciate that there is a bilateral optic nerve abnormalities, a thickened optic nerves demonstrating restricted diffusion, some area of restricted diffusion also in the oculomotor nerves in the cisternal segment, central tegmental tracts in the posterior fossa, the cisterns, the cerebral ponton angle cistern on the left side. There appears to be some lesion out there, demonstrating mild change of restricted diffusion. Even the internal canaliclar body on the 7th and 8th cranial nerves also appear to be thickened, demonstrating restricted diffusion. In terms of the parenchyma, I'm not able to appreciate any focal changes of diffusion abnormalities. On this sequence, you can appreciate some degree of volume loss, which will be better appreciated on the T2 sequences. But on these sequences, multiple cranial abnormalities stand out. On the T2 sequences, again, you have cerebral volume loss, but again, thickening of the optic nerves, some degree of thickening of the oculomotor nerves and the cisternal segments. You have this left cerebral ponton angles abnormality going up there and indenting in the brainstem on the left side. No areas of blooming on the express sequences. Post contrast, you have again enhancement of the oculomotor nerves, the bilateral optic nerves, the trigeminal nerves. You have enhancement and thickening of inflammatory thickening of the 7th and 8th cranial nerves on both sides. You have this lesion also demonstrating enhancement, almost resembling like an ice cream cone appearance out there. Spine was done, spine screening was done, and on the spine we had cervical myelopathy in terms of central areas of involvement. Some nodular focus along the perimedullary regions, which will be better appreciated on the contrast sequences. And on the post-contrast sequences, you have these multiple areas of nodular deposits or enhancing foci toward the entire extent of the cord, more predominantly in the cervical cord. There's also chordoica and nerve root enhancing changes. Yeah, so these were the main findings. I think Razi, there was no cranial nerve abnormalities or symptoms, right?
No cranial nerve deficits on examination, sir.
Yeah. Then once we saw, then no neurocutaneous markers also.
Yeah.
Okay. On the so additionally on these the contrast sequences, you can appreciate the nerve rootlets and the dorsal root ganglions also are thickened and demonstrated enhancement. So this was in the cervical region and also in the lumbosacral plexus. So yeah, multiple areas of involvement of the cranial nerves, also the cervical cord, the thoracic cord, and the corticoid nerves. Once we saw that case, we had a similar case which we discussed previously. We had this again multiple cranial nerve abnormalities in a 1.5-year-old child. This child at least had some cranial nerve deficits. And you can appreciate again, there was multiple areas of thickening of the cranial nerves. Various cranial nerves demonstrated diffusion changes and also some degree of enhancement on post-contrast study. And on the spinal cord, yeah, again, multiple nodular deposits or foci of enhancement, also involving the corticoid nerve roots. This child turned out to be ATRT at that point of time. So we are predominantly thinking of a neoplastic etiology for our case. And if there are any other, I think we also consider leukemia as one of the possibilities. Not sure if a bone marrow or cell count was done. Razi, any?
Yes, sir. Analysis was done today, sir. Proteins were 409, glucose was 24, and cell count was 6, lymphocytic predominant. ESR was 12, LDH was 213, and CBP ultrasound abdomen was not.
Okay. Just for radiologist inference of the labs?
Proteins were elevated with hypoglycemia.
Okay.
Like glucose was reduced.
Okay.
Any cytospin?
Sir?
Cytospins, right? Neoplastic
Malignant
cells.
cytology we have sent, sir. Report is awaited, sir. Today only we did bone marrow aspiration as well as LB.
Okay.
Yeah. Explain the clinical picture.
The which we saw, Dr. Yeah, the autistic picture, yeah. Failure to thrive also is there.
Yeah, presentation wise, decreased responsiveness and regression in speech was there, but significant weight loss with irritability was the handle, and we went ahead with MCET.
The weight loss was out of proportion to the presentation. Child was very irritable, cranky. It was very difficult to examine. He was just, clinging to the mother. But there were no neurocutaneous markers, no facial nerve that was seen on examination. So the only, the severe weight loss, it was more of like an irritability rather than autistic regression. But the child was not responding to anyone apart from only the mother.
Yeah. Okay. Yeah, on the chat also, I think ATRT GFAP maybe less like I think it's the K27 mutation. Abdul, without parenchymal involvement, only cranial nerve involvement. If yes, then yeah. TB, as Dr. Tajul has mentioned, do we have any signs of TB other than the weight loss? I don't think so.
We have no fevers, sir.
Yeah.
We have sent for gene expert as well.
Okay. So I think we agree that neoplasm is the first primary differential. I think malignant cells. Any plans for biopsy, Dr. Abhishek, or maybe this?
Like after this malignant cytology report,
Yeah.
if it is negative, then planning to decide on biopsies.
So if you see on the T1 where you see thin cut sequences, it is actually not involving the brainstem. It is only indenting on the brainstem. You can see the line of demarcation of the extraxal lesion from the brainstem. So all of these lesions are extraxal or predominantly involve the cranial nerves. Sorry, Dr. Nani. Yeah.
No, there's nothing parenchymal?
No, nothing parenchymal. All cranial nerves and cardiac nerve roots. So parenchyma, there are no lesions. Yeah. Okay. So yeah, we agree that high-grade malignancy, as Dr. Chirag has mentioned, is also embryonal tumor. Now we are thinking, Dr. Tajul, primary ATRT or neoplastic involving the cranial nerves. If you see in this case, we thought this was
even diffuse midline glioma can come like this, but nerves.
Yeah, so it's only nerves. I mean, midline glioma, at least I would have expected some of the brainstem should be involved, but the brainstem is completely normal, at least not in terms of the lesions or signal changes. Okay, so to conclude, I think we all agree that primary differential is a neoplasm. We'll wait for the malignant cells reports to come out, and we'll update it on the next session, and also the gene expert for TB. Okay, Razi, please let us know by next session.
Yes.
Thanks. All right, Anas, what do you?
So we have a 17-year-old boy born to third-degree consanguineous parents. He was apparently asymptomatic till 6 years of age. From around that time, when he had been sent to school, they noticed worsening scholastic performance and behavior. So it's difficulty in following instructions, reading, writing, increased forgetfulness. There was some, over time, there was self-laughing behavior, immature behavior, unable to memorize answers. This continued over time, to that degree that he was failing repeatedly. So past 3 years, they've dropped him out of school. He's helping in agriculture work, but he has no concept of money. The forgetfulness over time is worsening. Both immediate and old memories he's forgetting. This behavior is very labile. He laughs, then engages in self-laughter, but he has no aggressive behavior as such. So predominantly memory issues and behavioral issues. Over time, he has also developed walking difficulties. This was in the form of increased tightness, walking on toes, and falling when walking fast quickly. He walks stiffly and cautiously. He takes some support to climb up and down the stairs, but he is able to and crouches a lot. Uh, there was also over time they've noticed some fine motor issues like tremors on reaching for glass, but there's no spillage as such. He is able to do ADL activities, so whatever the motor difficulties are, they're not limiting his ambulation. He is able to dress, eat, use two-wheeler. In fact, vision and hearing has been normal. So general understanding is okay, but academic and scholastic and memory, these are major issues along with tightness. There was history of one episode of fever triggered seizure at 7 years, which recovered in a couple of days. There was not much encephalopathy, but they don't remember the history well. But at least it was a single event. There's no regression after that. Examination, he is thin built, but no micro or macrocephaly. He, again, labile behavior, immediate recall and distant recall both were impaired. Cranial nerve function was normal. The spasticity in lower limb, reflexes were exaggerated, and ill-sustained ankle firmness was there. Some upper limb cerebellar signs were there: intentional tremor, dysmetria, dysdiadokinesia. It was predominant spastic gait with some equinus and crouch. So, childhood onset progressive spastic diplegia with cognitive regression with some cerebellar syndrome. So, predominantly a HSP plus phenotype is what we are wondering clinically, but also possibility of late onset NBIA was also considered because of the spastic and but no dystonia. Other inborn metabolism treatable, we were wondering could it be something like a biotitinase deficiency, but these are more remote possibilities. Primary HSP plus or NBIA late onset ones were a clinical differentials. Then we went ahead with an MRI.
This child had two MRIs. I think the first one was on May 30th. Is that right, Razi? Yeah, it's on May 30th.
Yes, sir. I think
Okay.
prior to coming here, they had done the
Yeah.
MRI.
So I have only these images on film. You can appreciate again there is cerebral and cerebellar atrophy, slightly more in the supratemporal brain. If you concentrate on the temporal lobes, you have these confluent areas of subcortical deep white matter changes in the bilateral temporal lobes. In terms of the central structures, I'm not able to appreciate any signal changes or volume changes. Brainstem appears to be relatively preserved. Coming to the flare sequences, you can again better appreciate these confluent temporal lobe white matter changes on both sides. Some subcortical areas of involvement also demonstrated in the frontal and
पार्किंग में लगा देता हूँ गाड़ी, आप आराम से करो, मैं निकल जाता
parietal white matter. There is some thinning of the corpus callosum, but more on the body. Sphenium and genu are relatively better preserved in terms of volume changes in comparison to the body of the corpus callosum. I think the changes are better appreciated on the follow-up scan, but yeah, these are the main changes. I think cerebral and cerebellar atrophy with predominant temporal lobe abnormalities and some subcortical frontal parietal changes. No SWS sequence was available at that time to look for any mineralization. Yeah, so this is a follow-up scan done, I think, a couple of days back. So I can appreciate, again, there is volume loss in the supratentorial vein more than on the infratentorial vein. We have these subcortical white matter changes again in the frontal parietal lobes, but predominant abnormalities, as we have seen on the previous scan, are in the temporal lobes. And the flare sequence, again, you can appreciate the subcortical changes of the frontal white matter, some areas in the parietal white matter, but predominant changes are in the temporal lobes and also in the subinsular white matter.
पार्किंग में लगा देता हूँ, हाँ पार्किंग में लगा दो या आप जाओगे ऊपर से.
All right, on the SWS sequences, there is some globus pallidus, but for 17-year-old, I'm not sure if this is significantly increased. If you look at the cerebral peduncle substance nigra, yeah, these areas appear to be slightly more in comparison to the red nucleus, which you usually see take as a control for mineralization. So the hypointensity on the SWS is more in the cerebral peduncles. And on sand sequence, again, you can appreciate the supratentorial and infratentorial volume loss with callosal atrophy. Posterior fossa, there was no abnormal changes on the SWS sequences. Yeah, so these are the findings. We thought that this is such a neurodegenerative disorder with some degrees of increased mineralization and white matter changes. And we wanted the opinion of the group if there's any suggestions for this case. There are no ischemic abnormalities, no transient ischemic attacks. Possibility of cadasal was raised in the previous study, but clinically the child does not have any ischemic changes. So any other genetic abnormalities or other suggestions are welcome. All right, MBI, got it. Isa says MBI, Sridhar also MBI. Pawan says also MBI, yeah. Late onset gangliosidosis. See.
Sorry, I missed the beginning. It was a dementia, right?
No, I think Anas, if you can just quickly main points.
No, I got it. I'm
Okay,
reading.
yeah. So 2 6 years of age normal, and yeah, after that child has symptoms.
Done a CSF.
Anas? I don't think we have CSF.
No, sir. No, we have not done CSF.
No, I understand that it's most likely some genetic thing. The question is, will it be something acquired?
So we did consider SSCP as a SSP as a diagnostic differential, but he didn't have any seizures, slow myoclonus. So
No, but sometimes you can get Parkinsonian symptoms in SSP, right? Different types. How fast is he going down? Is it a very slowly progressive?
It's a very slow, sir. Very slow. Slow over this walking difficulty is over now 5 years. Slowly worsening. Very slow.
Okay.
And intellectual worsening is happening over 10 years. Still, he is able to participate in simple activities like agriculture work, and he's able to drive Activa by himself.
Okay, okay.
Autoimmune possibility?
9.
No, it's too long, I think.
I think GM, later onset GM1 could be,
Yeah.
GM2 could be one of the possibilities.
We have sent for genetics. We've given this handles. We'll update you once we have those.
Okay, so we agree, yeah. Genetic is likely, progressive neurodegenerative disorder. Gangliosidosis, NBI is to be considered. Homocysteine levels, Dr. Nindu Desai asks.
I think we have not done that, ma'am.
Good idea to get it done.
I will do it.
Homocysteine is normal.
Okay. Okay, so we'll get back to with the genetics again, thinking gangliosidosis, NBIs, and other genetic related disorders. Hopefully, we'll get a result out there. HIV, I don't think the Anas checked or.
I don't think so.
Okay, so we'll go ahead with primary consideration of a genetic neurodegenerative disorder. LFT, I think that's liver function test, if I'm not mistaken.
Was not done.
Not done. Not, okay. I don't think on the T1s I don't have the T1s, but yeah. Okay. Okay, we'll go ahead with genetics and we'll get back to you with the result. Yeah, thanks for the questions. Okay, Razi, how do you?
Yeah, so this is a 14-year-old girl presented with like history of pancreatitis in 2021, unknown etiology. Now presented with dullness since May 10th, then followed by headache, diffuse holocrinial associated giddiness 2 days later. There was no history of fever, vomiting, or imbalance while walking, or rash over the body. So first admission was from 22nd to 28th May 2025. During the time, the child was admitted outside hospital, where on examination, child was conscious, obeying commands, BPs were fine, and no extraocular movements were full, no facial asymmetry. Mild gait ataxia at admission was noticed, but parent didn't notice after admission, during admission. What parents have been told, like gait ataxia was there, and no signs of meningeal irritation or no significant lymphadenopathy was there. So initial first MRIs were done outside.
So this is the first MRI done on May 22nd. Yeah. And on the first MRI, you can appreciate again multifocal partially confirmed abnormalities, again deep gray nuclei involvement, capsular white matter involvement, medial temporal lobes, brainstem involvement, and also the cerebellar involvement. Yeah, on the T2 sequences. The flares demonstrate the same. They did not do an SWA sequence. So contrast was done, and contrast sequences, there was no significant enhancement other than this focus on the left middle cerebral peduncle. Yeah, there's some crowding of the CSS spaces and the posterior foramen of magnum because of the edematous changes, but other than that, no significant areas of enhancement demonstrated. Spectroscopy was done. Spectroscopy did not demonstrate any significant changes in terms of abnormal peaks. The child went on to have, I think, 3 more scans. So we'll get back to the latest scan once the investigations and the interval clinical discourse is mentioned.
Yeah, initial CSF was deferred because of tonsillar herniation. CBP was showing mild anemia. ESR was mildly elevated with normal LFTs and TFTs, renal function test, and ultrasound abdomen was normal. Respiratory biofire was negative. Infective etiology scrub, dengue and Lyme's, brucella IgG was negative, but brucella IgM was positive. Autoimmune workup, ANA, APLA, ANCA, and IgG4 were negative. Autoimmune and paraneoplastic panel was sent, which were negative. Virifast was sent from blood, which was showing virus 30. Initial pulse dose steroids were given for 5 days with mild symptomatic improvement and continued on later maintenance oral steroids.
Virus in the blood, significant, Razik? We had one case last week also.
Yeah, so last week case, we have sent to NIV Pune for confirmation, sir. That report came as negative from NIV Pune.
Okay.
So the child got readmitted with persistent headache. Second admission was in June from 5th to 20 with same complaints like persistent headache, neck pain, and slowing in the activities. But child was obeying commands. Blood pressures were fine, and mild dysmetria was there, and mild ataxia was there. But after 5 days of admission, increased headache associated with 3 to 4 episodes of vomiting. To repeat MRI was done. Child was again started on pulse methylpred and anti-edema measures, and IVIG was considered in view of worsening MRI changes. Headache and slowness improved on day 2 of steroids, converted to oral, and later PET-CT was also done. So initial viral meningoencephalitis post-viral Symbo virus was considered.
This
Okay,
readmission basically was noticed when they stopped steroids. Child was on steroids.
Okay.
When they stopped steroids, they noticed that the headache again increased and the child had to be readmitted. So that was one significant history for the second admission.
Okay. So this is the most latest scan. I think there's an interval of 1 month from the first scan, what we have seen on the, which was done on May 22nd. And on the most recent scan, you can again appreciate changes in the nuclear, but these restricted diffusion, I think, was not seen on the previous study, especially on the left basal ganglia capsular white matter. Again, the posterior fossa, there were some new lesions demonstrating restricted diffusion, especially on the right side. SWS sequences did not demonstrate any areas of microhemorrhage, at least in the abdominal areas. In terms of imaging, there is progression in comparison to the first study, and also there was gradual progression in terms of in the interval scan also on the 10th of June. So you have these additional changes in the cingulate cortex, frontal lobe cortex. You have more progressive confluent changes in the deep brain nuclei, the adjacent white matter. Thalami are more demonstrating progression in terms of changes. Also, the posterior fossa changes are slightly increased in the inferior cerebral hemispheres. Angio and Vino was done, which did not demonstrate any significant changes. Contrast wasn't done. So initially, I think the child was treated as post-infectious demyelination, but even on medication, I think though Dr. Abhishek has mentioned that child had stopped steroids, but there is interval progression in the imaging findings. I think we had discussed the possibility of an HLH, whether to be considered or not for this child, given that there is progressive changes in both supra and infratemporal brain. And this was just a companion case.
Basically,
yeah, sorry, Dr. And there was
this
no
child
other
basically
symptoms,
came for a second opinion from different hospital. While that time, like child was on a wheelchair, but conscious, understanding every command, was able to speak, was able to stand with some support, but was having difficulty in walking. So with this MRI, we thought of HLH. We just asked them to check for HLH. They've not come back again with the results.
Yeah, just to show the previous scan, which we had of similar Simbu, but which has not turned out to be negative. Again, we had multifocal abnormalities, particle, subparticle changes involving the gray and white matter structures. But yeah, this gradual progression was a concern, and I think people in the chat agree that HLH to be screened. Serum ferritin levels, Razi?
I couldn't find the reports, sir. Yeah.
Okay, got it. Diffuse glioma, Dr. Nilu, the first scan spectroscopy, at least we did not have any markers for neoplasm, and PET-CT also did not pick up anything. Sridhar mentions that CNH HLA3 to be tested. uremic hemolytic syndrome without microhemorrhages, without, yeah, maybe. MOGAD, it is progressing and not responding. I think MOG has come negative. MOG and NMO has come negative. I saw.
Yes, sir.
Okay, so yeah, I think we'll have to go with HLH screening and assessment as yeah,
Sir,
progressive
the
MRI. Sorry?
Brucella IgM was positive.
What was positive?
Brucella IgM
Oh.
initially, first admission. I haven't entered. IgG was negative, but IgM was positive.
But there would have been some improvement, no, Raji, over a period of 1 month of time. So,
Yes, sir. Despite treatment.
yeah, so we'll go. I think we agree with go with the HLH screen. Check for that. If negative, I think Dr. Abhishek will need a follow-up scan to see if there's any progression.
Yeah, certainly.
Yeah.
I mean, they'll just come back with that. If not, probably thought of trying another immunomodulator.
Yeah.
I think once we'll have to make sure we rule out HLH.
Okay. Glioma as a possibility has been raised. Yeah, we'll have to keep that also in mind.
I think multifocal glioma is not a bad job.
Yeah. It's not. I mean, progressing and not improving, especially the temporal lobes appear to be slightly mass-like. So we'll take it with HLH screening, and if negative, once the immunomodulation has been done, we'll get a follow-up scan and take a call on after that. I think that should be reasonable.
But he improved completely after the first attack?
Yeah, headache, I think it improved.
Symptomatically became better, sir. Not totally normal, symptomatically better. Like her speech was better. She was able to recognize, able to indicate her needs, although was requiring some assistance for walking and for her daily needs. So that was the only major change. On tapering steroids, they noticed the headache had become more severe, which required again readmission. Even because of that.
One he had seen had basically what looked like HSV encephalitis. You remember, Nilu? It turned out to be a glioma.
Yeah.
So, of course, this is extremely diffuse. It's going all over.
Yeah. We'll keep that in mind. Yeah, we'll do an HLH scan. Once the immunomodulation done, we'll get a follow-up scan and we'll get back to you with the follow-up scan and any intermediate results of the HLH. All right, last go here.
So this is a 12-year-old boy. So he had at 1.5 years of age, parent noticed some motor delay, isolated motor delay. Excuse me one second. Hello, sorry, some network issue. So walking delay noted from early childhood, walking with support at 1.5 years age, independent walking by 2 years. There was progressive balancing issues what the parents had noted. Initially it was very mild swaying, but from 4 years of age it became worsened. He had increased falls over time, which are worse in dark environment. He has also some difficulty in getting up from floor, up and down the stairs, difficulty in maintaining slippers, but there's no slapping sound when he walks. He's unable to pedal cycle, he just does half pedal. Difficulty in reaching for overhead objects and buttoning as well. So both proximal and distal, but lower limb more predominant. And past 3 years, they have noticed there's thinning of limbs as well. Currently, he walks independently, but otherwise he's dependent for all his needs because of the cognitive issues that develop from 4 years of age. Hyperactivity and inattention was there earlier, which became worse now. He speaks short sentences. He understands simple instructions, but still, despite being 12, he is not toilet trained and completely dependent for all activities like eating food, taking bath. At 3 years of age, they had identified some hearing issues, which was more on the right side, which was confirmed on investigations. Cataract was noted at 3 years, which was operated by 5. He requires prescription glasses, but he has no vision issues other than those cataract. Examination wise, he has inattentive, inconsistent eye contact, hyperactive, some autistic features were there from earlier as well. Extraocular movements are full range, some dysarthria, cerebellar type, tremors, some. Although the gait is not very wide base, he keeps like feet literally rotated. There is no facial bulbar weakness. Hearing is impaired both sides, right more than left. No xanthomas. No tongue fasciculations. This power upper limb 4/5, lower limb 3/5. There's some proximal to distal gradient. Along with that, there's some thinning of distal upper and lower limbs, more in lower limbs. Hyporeflexia. So he is not cooperative for proprioception, but tandem standing is not possible. Some intentional tremors are there. This is walking. He had a fall after which he rolled his ankle, so he has some difficulty. But this is what they say how he walks. He waddles a bit, keeps feet laterally rotated. So
Okay.
predominant phenotype wise, there's gradual regression, so motor delay and gradual progression. Both UMN and LMN features are there, like cerebellar cognition, along with some sensory neuropathy and some wasting. So multi-system involvement and multifocal involvement. Sorry, multifocal involvement rather than multi-system. Other systems are okay.
All right,
So
with
we
that,
were wondering, could it be like something like a mitochondrial because of SNHL cataracts, something like NARP? That was one differential we had. Or is it one of those SCA variants, but no spasticity? No xanthomas. We have not tested for serum cholesterol levels. And investigations, shall we go for MRI or?
yeah, we'll go for MRI and come back. All right, the MRI, I think, which was done again recently, you have some degree of cortical volume loss, but in terms of signal changes in the parenchyma, cannot appreciate any focal abnormalities or symmetrical changes in the brain parenchyma. The child update, the circumference appears to be hematocephalic, the frontooccipital dimensions are reduced, but yeah, there is a generalized cerebral and cerebral atrophy, more cortical based. The interauditory canals were reduced in diameter. We did not do a CT temporal bone, but yeah, they were in terms of measurements reduced. There is some pneumatization of the temporal bone, but other than the main findings of volume loss, maybe there is some the corpus callosum. I thought maybe in the anterior segment is appears slightly dysplastic and bulky, given that the child had generalized volume loss, but this corpus callosum has been maintained. But those are the main features on this on the T280 sequences. There are no other corroborative or associated changes on diffusion SWA sequences, flare sequences, or T180 sequences. So these are the representative images of the main findings on the brain. And on the spine, you can appreciate there is a reduction in the spinal cord volume almost to the entire extent. You can appreciate on the axial sequences reduced volume of the spinal cord. Yeah, so these are the main findings.
This get with juvenile Alexander's disease, but these are usually juvenile onset. This is, of course, they get very severe spinal cord and medullary atrophy.
Yeah,
what's the
it is amyotrophic. Subacromial junction and midlas. From there onwards, the cord has been atrophic. But juvenile, some signal change would have been there, Dr. Ulani, in the brainstem.
Not necessarily. The adult onset variety, of course, doesn't come with any change except in the spinal cord. But the problem is the early onset. So it doesn't clinically.
Yeah.
But the spinal atrophy.
Yeah, spinal cord atrophy is definitely there.
Any palatal myoclonus, juvenile Alexander's usually do have.
No palatal myoclonus, no polyminy myoclonus, no tongue fasciculations.
But the onset right? Motor delay and
Yes, sir. Initially, so so we have reviewed the past record also. Initially, at 1.5 years of age, it was just motor delay. Then over time, when he became 4, they noticed this behavioral issues. Then later, from 3 years onwards, hearing, cataract, and it's been slowly progressive over time. Now the current issues are falls are increasing. That's the main concern which they had come. So and then this thinning also was there. So we were, I think, around 2 years back, an NCS was done. It was distal axonal motor neuronopathy with sensory being present. We had not done a repeat NCS. This was done, I think, couple of years ago. This time he was not very cooperative, so we thought we'll do it on follow-up.
it looks like a more of a sensory neuropathy, right? From the clinical at least.
Yes, sir. From this NCS was couple of years ago. We have not done now again, but it was predominantly motor. Now I think the sensory symptoms are more because he's not able to perform Romberg and even worsening in eye closure.
Because the one which mitochondrial disorders come very often with sensory more than motor. The only thing it looks, yeah, exactly the Sando type. But this is, of course, usually very thin and this fellow is a big fat guy. So that
we have, I mean, there was simple genetics. We have a variant of.
We have a gene, but the UMN things did not match. I mean, although they have peripheral neuropathy and some myopathy, distal, and hearing loss, but the ATAC, this cerebellar or ataxia or thinning of spinal cord, these things, and then cortistic features and understanding issues, these were not matching. We had not done parental segregation. We had asked for reanalysis. But again, that didn't.
Mitochondrial mitochondrial genome or only VES?
Only VES.
It was only VES. We had not sent mitochondria at that point of time. So this was before we had done his spine. I mean, before the spinal thinning. So we're planning to expand our differentials and genetics based on feedback what we get, because the spinal thinning was slightly, I thought that maybe more diagnostic. In OMIM search, NARP and some
NARP by this age should have developed retinitis pigmentosa. So that is not there.
But we have not checked his fundus. We have not checked his retina now.
Yeah, not on cerebellar ataxia. NARP is usually cerebellar ataxia is predominant. Some of the paroxysmal disorders also have sort of this phenotype. They sort of mimic mitochondriopathy. It's very difficult to pick up on exome, but I think if you send a VLCFA and plasmalogen levels, maybe you might find a clue, and then you can deep search into the phenotypes and then get a clue. We had one case like that, thinking of mitochondrial CDG and all those things. Nothing turned up. Then we did a VLCF and plasmalogen, which came out to be elevated, and then a paroxysmal gene was found, PEX6 or PEX9, I'm not sure. But a similar phenotype.
Yeah, in the literature search, this paroxysmal disorders and congenital disorder of glycosylation also showed up, but we are wondering, will they, the progression is matching or not, I was not sure. But it's a good handle, we'll review that. VLCF, testable.
Okay, so just to summarize, I think parental segregation and maybe include genome sequence, mitochondrial genome, is that right? And then test for paroxysmal disorders.
Sure, thank you.
So, but you combine degeneration dystrophy, I think changes are to chronic consider subacute. Neurodegenerative spinal cerebral atrophy, yes, possible. But which one is what we have to look at?
Thought, riboflavin transpose the defect, because you can get axonopathy, neuronopathy, you can get sensory ataxia, you can get deafness. Usually you get lower cranial nerves, but these are basically variants of the PVT kind of thing. So The only thing is this little, you can at least give some treatment. I mean, I don't know this. You must have looked for it, nah? The WES.
So I'm not sure. Razi, can you check?
We'll check. No tongue fasciculations or limb fasciculation, finger fasciculation.
But your EMG.
We had not specifically mentioned for riboflavinopathy, but I'll just check if the exome covered it or not.
So reanalysis, mitochondrial to be included, peroxisomal to be included, and parental segregation. And once we get that, we can discuss that once we have all the results. Okay. Just to see if there are any, I did not put in the images, but there is no atrophy of the paraspinal musculature. It is again mentioned in this gene, which has material replacement of the paraspinal musculature. So we agree that the gene doesn't match, and then we have to further test for mitochondrial and the parental loops. Another lab investigations as mentioned. Razi, Anas, okay?
Thank you, sir. That helps.
Yeah. Okay, thanks. Payal, if you're there.
Hi, yes, sir, I'm here. So, this is the 17-year-old girl born out of non-consanguineous marriage. Birth history was uneventful and there was no past history of any illness. She has presented with the complaint of fever for 4 to 5 days, gone up to 102 as per the parents. It was like 1 month back history. Illness started around 5th to 6th June. Then during that time, there was multiple episodes of seizures. As per the parents, it was only generalized tonic-clonic seizures. And she was admitted elsewhere for 7 days, during which time it was told to the parents that some viral illness is there, for which she received the anti-seizure medication, levetiracetam and acyclovir with IV antibiotics and discharged. During that time, only MRI was done on day 5 of the illness. And she was sent to the home. At the home, she remained 3 days. There was no improvement, and there was an increased frequency of seizures, and started having episodes of vomiting. With the intermittent febrile episodes were there, but it was never documented. And she was again admitted in the pediatric hospital, and where symptomatic management was continued. But she deteriorated and came to us. On presentation, her GCS was near about 7 to 8, so she was intubated. There was pinpoint pupil, and Dolce was inconsistent. Tone of the all 4 limbs were in the lower side, and reflexes were elicitable. Plantars was upgoing, and other all systemic examination was normal. So we have proceeded, we have seen the MRI pictures. So I wanted to discuss those MRI pictures, because other than that, there is no history. And we have done the EEG, which was showing this periodic discharges at the 5 to 7 second interval.
Okay. With that background, the child was scanned on day 5 of illness, as Payal mentioned. Again, on day, you can appreciate on the T2A sequences, there are some areas of T2 hyperintensities in the periventricular deep, going up to the subcortical white matter on both sides, some degree of cortical volume loss, and also cerebellar volume loss on the T2A sequences. There is also hyperplasia or atrophy of the corpus callosum. The abnormalities are again better seen on the FLAIR sequences. You have multifocal, partially confluent changes in the cerebral white matter on both sides, periventricular, 2 subcortical regions. The internal capsules also demonstrate some degree of hyperintensities out there. And also thought that the middle cerebral peduncles appear slightly bright on the FLAIR sequences. So some degree of generalized volume loss. So with these predominant white matter changes going from the periventricular region to the subcortical regions on both sides, and possibly middle cerebral and brainstem involvement on the scans. Diffusion weight sequences did not demonstrate any corresponding changes of diffusion abnormalities, and SWI did not demonstrate any corresponding mineralization abnormalities or hemorrhagic changes. I think initially child was treated as demyelination, if I'm not mistaken, and sent back. Medications
No,
as
just like encephalitis, received the
encephalitis,
levetiracetam and the acyclovir. Yeah.
we thought that is there a possibility of SSP, the initial stages, at least on imaging wise, looks like that. But yeah, we wanted to have an opinion of the group.
Yeah, this MRI is done on the 8th or 9th June. So it's been almost for 25 days near about.
Okay.
And the CSF was done near about after 15 days into the illness. So CSF was negative. We have the remaining sample has been sent for the serum measles antibodies, but because they've been in the multiple hospitals, they have financially exhausted. So we wanted to know that how to proceed with this MRI, and we have given the because of the white matter changes, we have given the steroid doses. So little bit of response to pain is there, and today spontaneous eye opening was there. Other than that, no changes in the mental status. So anything with the MRI, we are planning to repeat the MRI, but this MRI done on the 5th or 6th day of illness. Anything we can conclude with that?
It looks like a more chronic process. No, I mean, 5th or 6th day or 20th day. Sorry, you mentioned both.
6th days. It was in the 9th June. The images were in the 9th June.
And child was already on steroids by that point of time?
No. Child during that time, child was not on this steroid. Now we have started.
So then the volume was not typical for a 5 to 6 day illness, and diffusion changes are, I mean, if we take this as acute changes, the diffusion was negative. So it's more of a chronic process. I think at least on imaging, which has clinical presentation may be more acute.
Okay.
RG says SSP, Sridhar also says phenotype fits SSP. No myoclonus, too early?
No. I asked multiple times the history. As per the parents, there was no typical history of myoclonus, and when the child was with us, child was already with a poor GCS, so we didn't see any. Today itself, one episode of seizure came, which was the left focal seizures, left tonic-clonic focal seizures.
Very acute presentation in acute fulminant type of SSP, you don't get myoclonus.
Yeah.
Okay, sir. Okay, sir.
You can check the eyes. Sometimes they have retinitis.
Okay, sir. Okay, sure, sir. Pupils are responding, but pinpoint. Yes, sir. I will check for that.
ASF changes, you send the antibodies, so it'll come probably.
Okay, sure, sir. Thank you so much.
Okay, so yeah, Payal.
Yes, sir. Thank you so much. Yes, sir.
The comments of Lucan, so the child was developmentally normal till 17. For genetic disorder, that would be slightly atypical.
Yeah, absolutely normal. Before that, there was no admissions.
Okay, so we're going with SSP as one of the prime possibility.
Okay, thank you so much, sir. Thank you so much.
Yeah, thanks, Payal. Sridhar is there, so we'll go back to Sridhar's case. I think that's the last case we have. Yeah, Sridhar, over to you.
Yeah, so this is a 4-month-old child, first born to non-consanguineous parents, presented with history of global delay, then visual impairment, not fixing and following, and extreme irritability with sleep fragmentation. On examination, microcephaly, absent visual fiction following, and generalized dystonia were observed. We did basic investigations like CPK, thyroid function test, and complete blood counts were normal. And based on history and this presentation, we thought of few clinical differentials. So any child with extreme irritability in early infancy, we think of either a Krabbe's, early infantile Krabbe, or a monoamine neurotransmitter disorder or something like that. So we went ahead with a CT scan first because parents were not that affording. So we wanted to discuss the CT scan, and then we can go further.
Yeah.
And Ekadi Gutier, yeah, these were the 3 differentials: early infantile Krabbe, Ekadi Gutier, and monoamine neurotransmitters.
All right. Yeah, CT has found multiple punctate calcifications, basal ganglia, thalami, subcortical, cortical regions. Also, if you see the circle spaces, I think the vessels in the circle space also demonstrate these areas of calcification out there. Pons has calcification along the ventral aspect. You have some punctate calcification in the cerebral hemispheres on both sides. I think there is some degree of cerebral atrophy. Some extraocular dilatation of the frontal horns. Maybe there is some volume loss of the caudate nuclei contributing to that. But if you look at the SAT sequences, it looks like the ventricular arteries or vessels are demonstrating these calcifications, this more linear branching type pattern seen on the SAG and the kernel sequences, which we commonly see in mineralizing lymphocyte vasculopathy or angiopathy like changes. Yeah, corpus callosum is diffusely thin for a 4-month-old. Yes, and also brainstem. If you look at the brainstem, there's atrophy of the midbrain pons. So yeah, some cerebral atrophy, callosal atrophy, brainstem atrophy with the calcification predominantly has this mineralizing or lenticule type pattern of calcification in the brain nuclear structures and lenticule vessels.
Yeah, so but that's what we also thought that this is a genetic etiology. So we directly also Dr. Nihaal, this MRI, the white matter signal is also hypo intense as compared to a normal white matter. No, this
is CT.
Subcortical white matter.
Yeah,
it is more
CT.
hypo intense. CT, yeah,
CT, no?
hypo.
Yeah,
intense,
it is. Yeah, I would agree, but the white matter is still not myelinated. So
we
yeah,
cannot say.
Yeah, I wouldn't be sure, but yeah, if you see for a 4-month-old, it's very difficult to differentiate unmyelinated white matter from the pathological abnormality changes.
Yeah. Okay.
But there is
So
definitely volume loss. There's calcification. I think there's some extraocular dilatation of the frontal horns, as you can see.
So yeah, based on this, we were sure that we are dealing with some genetic etiology. Definitely not lenticular striate vasculopathy, but a genetic etiology in view of global delay and visual concerns and irritability. So we sent genetics. Genetics came out to be this variant in DMEM63A, which is not at all fitting the phenotype.
Yeah.
So wanted the opinion of group on how do we proceed further. Any other radiogenomic handles? Reanalysis of exome we have asked for. Any other workup we should be doing?
Yeah, this is a good review paper if you want to check it out, but I think the genes would have covered most of the conditions out here. Interferonopathies, as you have mentioned.
No, CSF. The gene.
Yeah. Okay.
Because now you can do interferons also in the CSF.
CSF, yeah. No, I didn't mean mineralizing angiopathy as the condition, but if you look at
I understand.
it appears.
It's just looking like that pattern. I understand. No, but people were answering mineralizing angiopathy in the chat. That's why
okay. Sorry.
Yeah.
Liver thyroid function, I think, was basic test for them, which is normal. OCLN mutation, Abdul, usually has more subcortical curvilinear calcifications with some degree of polymicrogyria or malformation. So I think that would be slightly less on the differentials. Dr. Tajul asked how early was dystonia?
Yeah, this dystonia was in early infancy, since 1 month of age. Extreme irritability in the first 1 month, and classical dystonia parents noted as 1 month of age. They came at around 4 months to us. So yeah.
Opisthotonus?
Opisthotonus, yes.
I think interferon is prime consideration based on the imaging.
Sure.
Any plans for getting an MRI?
That's what we wanted to ask. That will MRI give us further clues, or we'll just see calcifications and some white matter changes? Because of the thing, the cost of MRI and the cost of exome reanalysis would be something around. So what to do further? We are not that sure. That's why we.
Dr. Udani, CSF, would that be lesser? I mean, cheaper?
Well, I think, see, clinically could very well be AGS.
Yeah.
CT scan also suggests AGS. If your genetics is negative, it's well worth doing a CSF and see the biome. Positive, I to go there. It costs $1,000 and done in Tata at Kharghar. That is a play. I forget Aptech or something of that sort.
Okay, so CSF interferon signature, sir. We'll proceed with that, no?
Yeah.
MRI not
Sure.
required, not Sridhar. Yeah, I agree.
Sure, sir. That's what we wanted to see, whether MRI would help or we will tell parents to do, because this is our first child. And another thing, yeah, consanguineous parents. So that's why we are thinking of genetic etiology. And no
Alright.
oculogary crisis, Dr. Taj. No oculogary crisis.
Cocaine, facial dysmorphism, skin changes, no liver abnormalities. Sridhar, does it match
No.
cocaine? I don't think so. No clinical phenotype.
No, it does not match cocaine. No classical faces.
Yeah.
No that.
Yeah, cocaine will have more chunky like calcification around this punctate. But yeah. So yeah,
CLCN5 mutation that have that band like pontine calcifications. That is also possibility. No?
Yeah, but the other calcifications are.
I think are not matching.
Yeah, not matching. Torch is, as I mentioned, torch hypomagnesemia. Hypomagnesemia, I'm not aware of calcifications in such an extensive pattern. Torch, any other findings other than calcifications?
No perinatal, no antenatal history of any fever or cough cold, and no other markers also. No failure to thrive. He was 3 kg child born.
And no hearing issues or?
No, hearing we have not checked, but he stutters to sound.
Okay. All right, so we'll give it deep sequencing and CSF for interferon signatures.
Sure, we'll do that, and I'll give a follow-up. So, yeah. Thank you.
Okay.
No proteinuria. No, not required clinically to check for proteinuria. Not have any handles.
Okay. I think that's should be our last case.
Thank you. Thank you.
Yeah, thank you. Yeah, that's the last case. So we'll see you again in a fortnight's time. Kindly send in your cases by the 15th of July.
Thank you.
Till then, bye-bye.
Thank you so much.
Take care.